This video illustrates thermal ablation technique for central compartment metastatic lymph nodes. This young patient underwent a total thyroidectomy for a 1.2 centimeter intrathyroidal papillary thyroid carcinoma in 2013. No remnant ablation was delivered at that time. However, a recurrence was noted requiring left central and lateral neck dissection. Subsequently, low-dose ablation was carried out. About a year ago, a 1.5 centimeter malignant lymph node was identified in left level 6 in the tracheoesophageal groove. This showed progressive enlargement. Patient was offered observation versus surgery versus radioactive iodine, and he opted for thermal ablation modality and was referred to us. The malignant lymph node here is identified in the left thyroid bed. We confirmed bilaterally mobile vocal cords on ultrasonography, as shown here on the ultrasound image. Doppler flow was evaluated to rule out the possibility of major vessels on the approach. For pain control, lidocaine was utilized around the lesion and the subcutaneous tissue. Between 3 to 5 ml of lidocaine, 2% was utilized. This was carefully injected around the lesion. This has been shown to have significant efficacy at mitigating discomfort and pain during the radiofrequency ablation procedure. One of the most common complications from radiofrequency ablation in the central compartment is recurrent laryngeal nerve injury, reported to be as high as 6%. To mitigate this, hydrodissection is a technique that is utilized. This technique involves, in this particular case, a lateral to medial ultrasound guided approach utilizing a 25 gauge needle that is attached to a syringe and cold D5W between 0 to 4 degrees centigrade. The tissue planes are gradually separated by bolusing D5W, as noticed here. As the tissue planes begin to separate, the needle is advanced and further boluses are applied. Our goal is to create a buffer zone between the metastatic lymph node and the tracheoesophageal groove, the location of the recurrent laryngeal nerve. This process is done very carefully, and the needle is advanced gradually along with gentle boluses until we can visually see a separation in the tissue planes. Boluses were given between 3 to 5 cc's at a time under real-time ultrasonography. As noticed here, a separation is developing between the node and the tissue planes, and a gradual buffer zone is being created between the tracheoesophageal groove and the malignant lesion. A total of 25 cc's of cold D5W was utilized for this. The needle was left in place and connected to a syringe and a bag of D5W. Hydrodissection was continued until we were satisfied with the creation of a buffer zone. Noticed here, a significant buffer zone has developed in the tissue planes between the recurrent laryngeal nerve and the lymph node. At this point, utilizing a medial to lateral approach, the electrode, which is a 0.5 centimeter active tip in the form of an 18 gauge electrode, is introduced under ultrasound guidance. A medial to lateral approach is recommended as this keeps the antenna away from the danger triangle, the location of the recurrent laryngeal nerve. The electrode is gradually positioned into our area of interest inside the malignant lymph node. Once you're comfortable with the active tip of the electrode being in the appropriate position, thermal ablation is initiated. Power is delivered here as noticed with the hyperechoic transformation of the zone close to the tip of the antenna in the middle of the recurrent cancerous lymph node. The electrode is moved around to different parts of the malignant lymph node, and ablation is continued until hyperechoic areas are developed throughout the target area and the entire lymph node is ablated carefully section by section. Hyperechoic zones typically symbolize effective ablation. Once all zones have been ablated, the procedure is stopped, and we confirmed bilaterally mobile vocal cords to confirm the absence of any injury to the recurrent laryngeal nerve.